Have you ever stopped to really wonder how your body performs its most incredible magic trick? Knowing exactly what belongs inside you and what doesn't.
It's fundamental, isn't it? That ability to distinguish self from non-self.
Exactly. It's at the very core of our survival. But what happens when that system goes wrong? When it turns on its own tissues, like in autoimmune diseases, or when it fiercely rejects a life-saving organ transplant, seeing it as like a foreign invader?
Yeah, when the defense system becomes the problem.
That's what we're diving into today. This deep dive, our mission is to pull back the curtain on the ingenious science of the immune system and the powerful drugs designed to modulate it.
Right.
We're going to distill the essential nuggets of knowledge from some pretty extensive scientific sources, really helping you master this complex information. You'll walk away feeling truly well-informed, quickly and clearly, understanding the intricate balance and the powerful tools involved.
It truly is an incredibly delicate balance. Almost like trying to conduct a vast, highly trained orchestra where every instrument has to play in perfect harmony.
Yeah.
But sometimes you need certain sections to quiet down without stopping the entire performance. That's the challenge when we manipulate the body's defenses. Our sources for this, they cover everything from the foundational immunology, how this incredible system operates, all the way to the cutting-edge pharmacological interventions. That includes the major classes of immunosuppressive drugs and these newer targeted immunomodulators that are currently reshaping how we treat really complex diseases.
And that's exactly the high wire act we're exploring. How do we suppress the immune system enough to prevent the catastrophic rejection of a new organ or to halt its destructive attack on the body's own tissues?
Right, stop the friendly fire.
While still maintaining enough defense to ward off everyday infections and even keep potential cancers in check. It's a profound therapeutic tightrope, and we'll explore how these powerful drugs manage it. So let's unpack the core idea that underpins all of this. How does our body actually tell the difference between self and non-self? This fundamental ability is absolutely crucial to understanding everything else we're going to discuss about immune modulation.
It truly is the foundational principle. Our immune system operates with two main interconnected arms. First, you have innate immunity.
Innate. Okay.
Think of this as the body's ancient first responder system.
Yeah.
It's primitive, yes, but incredibly effective and broadly reactive. It's designed to instantly recognize common molecular patterns found on dangerous microorganisms, signatures that just scream invader.
Like a general alarm.
Exactly, a general alarm. Its major effectors are a rapid response team. You've got complement proteins, which literally punch holes in invading cells. Granulocytes, like neutrophils that engulf and destroy pathogens. Monocytes and macrophages, these incredible phagocytes that gobble up debris and invaders. Natural killer, or NK cells, which kill infected or cancerous cells without prior programming, really. And other crucial players, like innate lymphoid cells, mast cells, and basophils. This system springs into action very early in an immune response, providing immediate protection while the more sophisticated system gears up.
So it's like a general alert system, very fast, but maybe not super specific. And then there's the other arm.
Exactly. That's where the adaptive immunity comes in, often called learned immunity.
Yeah.
This is where the true sophistication lies. It's antigen specific, meaning it literally learns from each unique exposure to a specific threat.
It remembers.
It remembers, and it can develop incredibly high affinity for very precise targets, allowing for a highly specialized and frankly potent attack. The major players here are these specialized lymphocytes, B and T cells.
B and T cells. Okay, I've heard of those.
Right. B lymphocytes, when activated, are like the body's precision missile factories. Their primary role is to produce antibodies. These antibodies are molecular marvels, designed to recognize a vast array of specific structural conformations on invaders, literally latching onto them like a lock and key.
So they target specific shapes.
Specific shapes, exactly. T lymphocytes, on the other hand, have diverse and crucial roles. You can think of them as the special forces unit, maybe.
Okay, I like that analogy.
We have helper T cells, which are the orchestrators, coordinating the entire immune response, sending out signals to other cells. Then there are cytolytic T cells, sometimes called killer T cells.
The assassins.
The direct assassins, yeah. They're capable of directly killing cells that are infected with viruses or have turned cancerous. And finally, we have regulatory or suppressor T cells. These are absolutely vital for modulating the immune response, ensuring it doesn't overreact and cause, collateral damage to our own healthy tissues. This last group plays a crucial role when we talk about preventing autoimmune diseases or managing organ transplantation.
So these specialized cells are absolutely vital for fighting off infections and tumors, but quite surprisingly, they are also the very mechanisms that lead to transplant rejection and cause autoimmune diseases when they get confused, I guess.
Precisely, when the targeting goes awry.
This is where it gets truly fascinating for me. How do they actually see their targets? What's their vision system like?
That's a great way to put it. And it highlights a key difference between B and T cells. B cells, through their immunoglobulins, which are essentially antibodies stuck on their surface, can directly recognize specific shapes or structures on antigens.
Like we said, the lock and key.
Exactly, directly fitting onto the invader's surface, whether it's a bacterial toxin or a viral protein. T cells, however, are a bit more discerning. They don't just see whole antigens floating freely.
Oh, man.
No. Instead, they recognize tiny peptide fragments, little pieces of proteins that have been processed inside other cells and then presented on the surface of those cells. And they're presented within the context of what we call major histocompatibility complex, or MHC proteins. Think of MHC proteins as specialized display cases that hold up these molecular fragments for T cells to inspect. It's like showing a sample.
Okay, display cases, so there are different types.
Right, two main types. MHC class II proteins, known as human leukocyte antigens or HLAs in humans, are primarily found on what we call professional antigen-presenting cells, or APCs.
APCs, like scouts.
Like vigilant scouts, exactly. Dendritic cells, macrophages, they pick up fragments from extracellular invaders. Think bacteria hanging out outside our cells, and they present these fragments using MHC2 to helper T cells. They're essentially saying, look what I found outside, we might need backup.
Okay, so MHC2 is for external threats presented by scouts. What about MHCI?
Then there's MHC class I. This is expressed by virtually all nucleated cells in your body. Every cell with a nucleus has this. This system is designed to display fragments from intracellular threats.
Inside the cell, like viruses.
Like viruses replicating inside your cells, or maybe abnormal proteins from a cell that's becoming cancerous. So if a cell's infected or has turned cancerous, MHCI puts out a molecular help me signal, presenting a piece of the problem to those cytolytic T cells, the killers. It's essentially saying, I'm compromised, you need to destroy me to save the organism.
Wow. So once a T or B cell successfully identifies its target through these very specific recognition systems, MHC or direct binding, what happens next? Does it just go into attack mode immediately?
Not quite immediately, but it triggers a really powerful activation cascade.
Yeah.
Once a B or T lymphocyte is activated by this specific antigen recognition, the right key fits the lock, it receives signals to divide rapidly and differentiate.
Or soldiers.
Exactly. This is how the immune system rapidly builds a specialized army clones of these specific cells to deal with that particular threat. This activation also leads to the release of soluble mediators, like cytokines and chemokines.
Chemical messenger.
Right, chemical messengers. Cytokines can amplify the immune response, activate other cells, tell cells when to fight, when to die. Chemokines act as GPS signals, basically, recruiting more immune cells to the site of infection or inflammation. And in the case of B cells, this activation leads to the mass production of those highly specific antibodies we talked about, which then circulate throughout the body to neutralize threats wherever they find them. It's a tightly regulated, highly effective system when it works correctly.
Now that we understand the players, the cells, the signals, the MHC display cases, let's talk about reining them in. Why do we even need to dampen this incredible immune response? It sounds so counterintuitive, given its protective role.
It's a great question, and it really is counterintuitive until you understand the clinical context where it's absolutely necessary. We need to strategically dampen or suppress the immune response in two primary clinical scenarios. First, and perhaps most dramatically, in organ transplantation.
Right, the rejection problem.
Exactly. When someone receives a donated organ, like a kidney or a heart, the recipient's immune system will naturally recognize that organ as non-self because it carries different MHC-HLA markers, different molecular flags, essentially. Without immunosuppression, the immune system would mount a powerful, immediate attack and swiftly reject the new organ, leading to graft failure, which can be catastrophic.
And the second scenario?
The second major use is an autoimmune disease. Here, the problem isn't an external invader, but the immune system mistakenly attacking the body's own healthy tissues. The system gets confused about self.
Friendly fire, like you said.
Precisely. This can lead to debilitating conditions like rheumatoid arthritis, lupus, multiple sclerosis, where the immune system is literally causing harm from within. In these cases, immunosuppressive drugs are used to calm that misdirected immune attack, preventing further damage to the body's own vital organs and systems.
Our sources highlight 4 major classes of immunosuppressants used today, especially in transplantation. Can you give us the main groups?
Sure. The main classes are glucocorticoids, which are broad anti-inflammatory steroids, things like prednisone. Then calcineurin inhibitors like cyclosporine and tacrolimus, which target a key enzyme in T-cell activation. Third, antiproliferative anti-metabolic agents, such as azathioprine or mycophenolate, which disrupt immune cell division. And finally, various biologicals, which primarily refers to highly targeted antibodies or fusion proteins.
Biologics, that sounds more modern.
It is, generally. And what's crucial to understand is that these drugs are almost always used in combination. Our sources provide excellent summaries showing how they target different steps in that complex T-cell activation pathway we discussed. It allows for a strategic, multi-pronged attack to achieve optimal immune suppression without relying too heavily on any single agent.
But these powerful tools, while life-saving, surely come with significant trade-offs, right? It can't be a simple on-off switch.
You're absolutely right. This is the core dilemma of immunosuppressive therapy. It's a constant balancing act. For one, it often requires lifelong use, especially in transplantation, meaning patients are on these drugs indefinitely, year after year.
Wow, lifelong.
Yeah. The biggest challenge, though, is what we call nonspecific suppression. These therapies, particularly the older ones, don't have a laser focus. They suppress the entire immune system, not just the bad immune response causing rejection or autoimmunity. This leaves patients highly vulnerable to serious, even life-threatening infections, from common bugs to opportunistic ones. And it significantly increases their risk of developing certain cancers, because the immune system's surveillance function, its ability to spot and eliminate rogue cells, is weakened.
That's a huge risk, infections and cancer.
It is. And then there are the specific toxicities of these powerful drugs. For instance, calcineurin inhibitors are notoriously nephrotoxic. They can directly damage the kidneys.
Which is terrible if you just got a kidney transplant.
Exactly. It's a major concern, especially for kidney recipients whose renal function might already be fragile. And daily, long-term glucocorticoid use is diabetogenic. It frequently causes high blood sugar and can even trigger new-onset diabetes. These severe side effects can severely restrict their long-term usefulness, compromise overall health, and significantly impact a patient's quality of life. The clinical art lies in constantly balancing these risks with the profound benefits of preventing rejection or controlling autoimmunity.
So the goal is clearly to be more precise, right? To limit those trade-offs and be less of a blunt instrument. What are some of the newer, more targeted approaches emerging in the field that aim for this kind of precision?
The field has certainly evolved significantly, moving beyond just broad suppression towards more targeted strategies. Newer approaches include the development of highly specific monoclonal and polyclonal antibody preparations.
Like guided missiles.
Kind of, yeah. These are engineered to precisely target specific immune cells, like particular T and B cell subsets, or even specific inflammatory mediators like cytokines, those chemical messengers. Targeting TNF-alpha, for example, has revolutionized treatment for various autoimmune conditions.
Ah, like the ads you see for arthritis drugs.
Exactly. Many of those target TNF-alpha. And we have biologicals designed specifically to deplete B cells, like anti-CD20 antibodies. These are now crucial treatments for conditions like relapsing, remitting, and primary progressive multiple sclerosis, showing B cells play a bigger role than we once thought.
Interesting. What else is new?
We're also seeing the emergence of newer small molecules and antibodies that expand our therapeutic arsenal. This includes inhibitors of the mammalian target of rapamycin, or mTOR drugs like sirolimus, everolimus, and temsirolimus. These block pathways crucial for cell growth and proliferation. There are also antibodies targeting growth factor pathways, such as anti-CD25 antibodies like basiliximab and daclizumab, which specifically block the interleukin-2 receptor on T cells, stopping that key growth signal. And importantly, we have agents that inhibit T-cell co-stimulation, that crucial second signal we talked about, like belatacept.
Blocking signal 2.
Exactly. The aim with all these innovations is to limit the clonal expansion of specific immune cells, and ideally to promote a state of immunological tolerance, where the body's immune system learns to accept the non-self, the transplant, or stops attacking self without needing broad, dangerous suppression. That's the ultimate aim.
Let's get into the strategy for organ transplantation specifically. Our source breaks it down into 5 general principles that guide how this complex therapy is approached.
Yes, these 5 principles are absolutely critical for successful transplantation and managing the patient long term. They provide a framework. First, careful patient preparation and matching are paramount. This means ensuring ABO blood type compatibility, that's basic, but also performing extensive human leukocyte antigen, or HLA, matching for organ donation.
Matching those MHC markers we talked about.
Precisely. This initial step is your first and best line of defense against immediate rejection. It's about minimizing that non-self signal from the very beginning, setting the stage for success. Second is the use of multi-tier immunosuppressive therapy. This isn't about relying on one superdrug, it's about harnessing synergy. Clinicians use several agents simultaneously, each directed at a different molecular target within the complex allograft response to the rejection pathway.
So it's like a cocktail approach, right? It's drug doing its part to hit different targets, allowing you to use less of each powerful drug. That makes sense for reducing side effects.
Exactly. It limits specific toxicities while maximizing the overall immunosuppressive effect needed to protect a new organ. And third, there's a strategic shift in drug intensity. We move from intensive induction to lower dose maintenance protocols.
Induction first, then maintenance.
Right. When a patient first receives an organ, strong immunosuppression, known as induction therapy, is required to gain early engraftment, essentially, to ensure the new organ integrates successfully and isn't immediately attacked. High doses are also used to treat established rejection episodes if they occur. However, as the acute rejection risk lessens over time, the focus wisely shifts to reducing the cumulative side effects of the medications. So patients transition to lower maintenance doses over the long term. It's a constant clinical negotiation. The fourth principle is thorough investigation of transplant dysfunction. If an issue arises with the transplanted organ, maybe the kidney function starts declining, it's vital to systematically evaluate it for multiple possibilities.
It might not just be rejection.
Exactly. It could be a recurrence of the original disease that led to the transplant in the first place, or it could be acute rejection, or it could be drug toxicity, the meds themselves harming the organ, or it could be an infection. The source stresses that these problems can and often do coexist. So a comprehensive diagnostic approach, often including a biopsy of the transplanted organ, is absolutely essential to pinpoint the problem and guide the right treatment. Finally, the fifth principle involves that constant clinical balancing act. Dose reduction or withdrawal based on toxicity versus benefit. Clinicians must continuously assess whether the benefits of the drugs in preventing rejection outweigh their adverse effects. If the toxicity becomes too great or threatens the patient's overall health, adjustments, lowering doses, switching drugs, maybe even complete withdrawal of a particular agent may be necessary, always weighing the risk of rejection against the drug's harm. It's a dynamic, patient-centered decision, constantly reevaluated.
Diving into that induction phase you mentioned, our sources specifically highlight biological induction therapy. What exactly does that mean, and why is it so important early on?
Biological induction therapy refers to using specific, potent biological agents, often antibodies, right around the time of transplantation. Its primary purpose is twofold. Either to delay the use of those potentially nephrotoxic calcineurin inhibitors, giving the new kidney a bit of a break,
Okay.
or to intensify the initial immunosuppression for patients who are at a higher risk of rejection. High-risk patients might include those undergoing repeat transplants, patients who are broadly presensitized, meaning they've developed antibodies from previous exposures like transfusions or pregnancy.
So their immune system is already primed to react?
Exactly. Also, African-American patients often have higher rejection risks, and pediatric patients have unique considerations. So for these groups, you might hit harder up front. This strategy actually has deep historical roots. As early as the 1960s, pioneers like Dr. Thomas Starzl and his colleagues demonstrated the beneficial effect of anti-lymphocyte globulin, or ALG, in preventing rejection.
ALG attacking lymphocytes.
Right. Today, 2 preparations are FDA approved and widely used. Lymphocyte immune globulin, known as ADGM, and antithymocyte globulin, or ATG, marketed as thymoglobulin. ATG is currently the most frequently used depleting agent for induction. It actually removes T cells. There's also alemtuzumab, a humanized anti-CD52 monoclonal antibody. While it's officially approved for things like leukemia and multiple sclerosis, it's increasingly used off-label for induction and transplantation because it causes profound and prolonged lymphocyte depletion.
And how have these antibodies themselves evolved over time? I imagine we've gotten better at making them less foreign.
Absolutely. The evolution of these antibodies is a fascinating story of scientific refinement. Early murine-based monoclonal antibodies, meaning they were derived from mouse cells, had limitations because the human body would recognize them as foreign and develop anti-antibody responses.
Your body attacks the drug.
Exactly, which reduced their efficacy and shortened their half-lives. This led to the development of chimeric antibodies, which contain about 33% mouse protein and 67% human protein. Then further to humanized antibodies, which are 90%, 95% human, or even fully human antibodies, which are 100% human protein sequence.
Getting closer and closer to our own structure.
Precisely. While all three human-derived types are effective, chimeric antibodies can still sometimes elicit an anti-antibody response, leading to reduced efficacy compared to the humanized or fully human antibodies. Currently, biological agents for induction therapy are used in approximately 70% of de novo transplant patients, those receiving their very first transplant, so it's very common. These agents generally fall into two groups. The first group is depleting agents. Their efficacy comes from their ability to actively deplete the recipient's CD3-positive T cells at that crucial time of transplantation and antigen presentation. Examples include lymphocyte immune globulin, ATG, and teplizumab CD3 monoclonal antibody. An older mirroring version, miremonab CD3, is no longer used in the U.S. because of side effects.
So they just wipe out the T cells temporarily.
Pretty much, yes. The second group comprises immune modulators. Specifically, these are the anti-IL-2 receptor monoclonal antibodies, like basiliximab and teclistamab. Unlike depleting agents, these do not deplete T lymphocytes. Instead, they work by blocking interleukin-2-mediated T cell activation by binding to the alpha chain of the IL-2 receptor, that's CD25.
Blocking the go signal from IL-2.
Right. It prevents T cells from fully activating and proliferating, but the cells are still there. Now, for patients who present with high levels of anti-HLA antibodies and signs of humoral rejection, that's rejection driven by antibodies, not just T cells, even more aggressive therapies are needed. These can include plasmapheresis to physically remove antibodies from the blood, intravenous immunoglobulin, IVIG, which can neutralize harmful antibodies, and rituximab, a chimeric anti-CD20 monoclonal antibody designed to deplete B cells, the source of those antibodies.
So after this intense induction phase gets the organ settled in, what about maintenance immunotherapy for the long haul? How do we keep the immune system quiet but not completely shut down, potentially for years?
Once that initial critical period is over and the new organ has successfully engrafted, the focus shifts to long-term maintenance. Basic maintenance immunosuppressive therapy typically involves a multi-drug regimen used simultaneously. The standard approach usually combines a calcineurin inhibitor, glucocorticoids, and mycophenolate, which inhibits purine metabolism.
The triple therapy mainstay.
Often, yes. The reason for this combination, as we've discussed, is that each drug is directed at a discrete step in T cell activation, providing that crucial multi-pronged approach. This lets you keep the immune system in check with lower individual drug doses, thereby reducing the long-term side effects of each. Beyond these core three, many other approved drugs can be part of the maintenance regimen. This could include azathioprine, cyclosporin, tacrolimus, sirolimus, belatacept, and various monoclonal and polyclonal antibodies depending on the situation. The specific combination and dosages are highly individualized, based on the patient's risk profile, the type of organ transplanted, how they're responding to the therapy, side effects. It's a constant adjustment, really.
What happens if, despite all these carefully crafted strategies, rejection still occurs later on? It must be devastating for the patient.
Unfortunately, yes. Even with the best protocols, rejection can still happen, either acutely or chronically. When it does, the lower doses used for prevention and maintenance therapy are often insufficient to reverse an active rejection episode. Therapy for established acute rejection requires a more aggressive approach, typically using agents specifically directed against activated T cells.
Hitting it hard again.
Hitting it hard. This often includes very high doses of glucocorticoids given as pulse therapy, short bursts of high-dose steroids, or potent polyclonal anti-lymphocyte antibodies like ATG again. It's important to note, however, that while these are quite effective for acute rejection, these treatments are generally less effective against chronic rejection.
Chronic rejection. That sounds different.
It is. Chronic rejection is a slower, more insidious form of damage to the transplanted organ that often involves gradual scarring, fibrosis, and loss of function over months or years. It's harder to treat effectively once established.
Right. Let's now really dive deep into each of these major drug classes, getting into the specifics of how they work, how the body handles them, and their unique considerations. First up, the real workhorse of immunosuppression for decades. Glucocorticoids. These steroids have been around for a long time, right?
Indeed, glucocorticoids with familiar names like prednisone, prednisolone, methylprednisolone. They've played an absolutely pivotal role in medicine. Their introduction as immunosuppressive drugs back in the 1960s was truly key to making organ transplantation a viable and widespread treatment option. They have incredibly broad anti-inflammatory effects, impacting multiple components of cellular immunity. It's worth noting, though, they have relatively little direct effect on humoral immunity, the antibody side of things.
So mostly cellular immunity. How do they work so broadly?
Their mechanism is quite complex because they affect so many pathways. Glucocorticoids work by binding to intracellular receptors. This complex then moves into the nucleus and regulates the transcription of numerous genes, turning some off, turning some on. They effectively calm the entire inflammatory cascade by suppressing the formation of a wide range of pro-inflammatory cytokines like IL-1 and IL-6. They also directly inhibit T cells from producing IL-2, that key growth factor, and stop them from proliferating. Plus, they inhibit the activation of cytotoxic T lymphocytes, the killer cells. Additionally, they impair how immune cells like neutrophils and monocytes migrate to sites of inflammation. They can't get to the battlefield as easily, and they decrease the release of destructive lysosomal enzymes from these cells. So it's a very broad dampening effect.
Given that widespread impact, they must have a lot of uses.
Absolutely. They're commonly combined with other immunosuppressive agents to prevent and treat transplant rejection. They're also highly effective for treating graft versus host disease, or GVHD, in bone marrow transplantation, where the donor's immune cells attack the recipient. Beyond transplantation, glucocorticoids are routinely used for a vast array of autoimmune disorders: rheumatoid arthritis, other arthritides, systemic lupus erythematosus, systemic dermatomyositis, psoriasis, asthma, many allergic disorders, inflammatory bowel disease, inflammatory eye diseases, autoimmune blood disorders, acute exacerbations of emascript. The list is long. They also help limit allergic reactions to other immunosuppressives and can prevent that intense cytokine storm or cytokine release syndrome that can happen as a first-dose reaction to strong antibody treatments like ATG.
That sounds almost like a wonder drug covering so many bases, but I know there are significant downsides, especially long-term. What are the major toxicities that clinicians have to constantly manage?
You're right to point out the downsides. While incredibly effective, extensive or long-term glucocorticoid use often leads to disabling and even life-threatening adverse effects. It's a major trade-off. In children, this can manifest as significant growth retardation. For adults, common issues include osteopenia leading to fragile bones and fractures, even a vascular necrosis of bone, where bone tissue dies due to lack of blood supply.
Ouch.
Yeah. Also, increased risk of infection due to the generalized immunosuppression, poor wound healing, cataracts, hyperglycemia, which can lead to or worsen diabetes, and hypertension. The good news is that with the advent of modern combination regimens, particularly using glucocorticoids with calcineurin inhibitors, clinicians can often use much reduced doses or even rapidly withdraw steroids altogether in many transplant protocols, especially in pediatrics. This has significantly lowered the incidence of these severe steroid-induced morbidities compared to the early days.
Okay, so that leads us nicely to the next major class, the calcineurin inhibitors. You've mentioned these are among the most effective, but also have their own set of challenges, particularly kidney toxicity.
Indeed, calcineurin inhibitors, primarily cyclosporine and tacrolimus, are absolute cornerstones of modern immunosuppression, especially in transplantation. They are highly effective. Their shared mechanism is quite elegant. They target specific intracellular signaling pathways that get kicked off when a T-cell receptor recognizes its antigen on an MHC molecule.
Signal 1 again.
Right after signal 1.
Yeah.
Both cyclosporine and tacrolimus bind to specific intracellular proteins called immunophilins. Cyclosporine binds to cyclophilin, and tacrolimus binds to a protein called FKBP12. This binding event then allows the drug immunophilin complex to interact with and block the activity of an enzyme called calcineurin.
Okay, so they block calcineurin. Why is that so important?
Because calcineurin is a phosphatase, an enzyme that removes phosphate groups. It needs to dephosphorylate a component of a transcription factor called NFAT, nuclear factor of activated T lymphocytes. This dephosphorylation allows NFAT to move into the nucleus. Once in the nucleus, NFA is essential for turning on the genes for critical cytokines, especially IL-2, which is the main T-cell growth and differentiation factor, but also other important ones. So by blocking calcineurin, these drugs effectively shut down the production of IL-2 and other key cytokines, which halts T-cell activation and proliferation right in its tracks. It's fascinating because even though cyclosporine and tacrolimus bind to different initial intracellular receptors, they ultimately converge on the same critical pathway to achieve immunosuppression.
Very targeted, then, on that specific pathway. Let's focus on tacrolimus first. You mentioned it's often preferred now.
Yes, tacrolimus is often preferred in many transplant centers, perhaps due to a perception of slightly greater efficacy in some studies and maybe somewhat easier blood level monitoring compared to older cyclosporine formulations. It's a powerful macrolide antibiotic, originally isolated from a soil bacterium in Japan. What's crucial to know about tacrolimus from a practical standpoint is its pharmacokinetics, how the body handles it. Its absorption from the gut after taking a capsule is incomplete and highly variable between individuals, and it's often decreased by food. It's also extensively metabolized in the liver, primarily by a group of enzymes called CYPs, specifically CYP3A4 and CYP3A5.
Ah, those CYP enzymes, again involved in lots of drug metabolism.
Exactly. This means its levels in the bloodstream can vary wildly from person to person and even day to day in the same person. Plus, many other drugs can interfere with those CYP enzymes, raising or lowering tacrolimus levels. This makes careful, individualized monitoring of blood levels, usually trough levels, right before the next dose, absolutely essential to ensure it's both effective, preventing rejection, and safe, avoiding toxicity. Target levels also change over time, typically higher early post-transplant and lower for long-term maintenance.
Okay, so monitoring is key. What's it used for, and what are the main side effects to watch out for?
Therapeutically, tacrolimus is primarily used for the prophylaxis, the prevention of solid organ allograft rejection kidney, liver, heart, lung, etc. It's also used off-label sometimes as rescue therapy for rejection episodes that haven't responded to cyclosporine or other treatments. Dosing varies quite a bit based on the organ, the patient, other meds, and the specific formulation being used, standard versus extended release. Now, for its toxicities, which are significant and often dose-limiting, nephrotoxicity is a major concern. It can directly damage the kidneys. Neurotoxicity is also common, manifesting as tremor, headache, sometimes more severe motor disturbances, or even seizures. Gastrointestinal complaints are frequent. Hypertension is common. Electrolyte issues like hyperkalemia, hypotassium can occur. And importantly, hyperglycemia and diabetes. Tacrolimus seems to negatively affect the pancreatic islet beta cells that produce insulin. The incidence of new-onset diabetes after transplantation is significantly higher with tacrolimus compared to cyclosporine, especially in certain patient groups like obese individuals, African Americans, Hispanics, or those with a family history of type 2 diabetes.
That's a really important distinction from cyclosporine.
It is. Like all immunosuppressants, it increases the risk of secondary tumors and opportunistic infections. A key differentiating point from cyclosporine, though. Tacrolimus does not typically adversely affect uric acid levels or LDL cholesterol. Some other common side effects, especially when used with mycophenolate, include diarrhea and alopecia, hair loss.
And drug interactions, given the CYP metabolism?
Absolutely crucial to manage. Because it's processed by the CYP3A45 enzymes, many other medications can significantly alter its blood concentrations, requiring dose adjustments and close monitoring. For example, some antifungal drugs like ketoconazole, certain antibiotics like erythromycin, calcium channel blockers like diltiazem, and even grapefruit juice can inhibit the enzymes and dangerously increase tacrolimus levels. Conversely, drugs like rifampin, an antibiotic, or certain anticonvulsants like phenytoin, carbamazepine, can induce the enzymes and decrease tacrolimus levels, potentially leading to rejection. Co-administration with cyclosporine leads to additive or synergistic nephrotoxicity, so you need at least a 24-hour gap when switching between them. Concomitant use with cyclosporine or sirolimus is generally not recommended for routine prophylaxis against renal transplant rejection due to these combined toxicities.
Okay, that's a lot to consider with tacrolimus. Now let's talk about cyclosporine. It was the first calcineurin inhibitor, wasn't it? A real game changer.
It absolutely was. Cyclosporine, a cyclic polypeptide, derived from a fungus, really revolutionized organ transplantation in the late 1970s and early 1980s. Before cyclosporine, outcomes are much poorer. Like tacrolimus, its mechanism involves forming a complex with its immunophilin, cyclophilin in this case, binding to calcineurin, and inhibiting NF8 dephosphorylation. This ultimately blocks the gene expression for IL-2 and other crucial lymphokines, as well as some anti-apoptotic proteins that help T cells survive. It's particularly effective against those T-cell-dependent immune mechanisms that drive transplant rejection and some autoimmune diseases, although it does suppress some humoral immunity too. Interestingly, it also seems to increase the expression of transforming growth factor beta, TGF-beta, a cytokine which itself can inhibit T-cell proliferation and promote regulation.
How does its handling by the body compare to tacrolimus?
There are similarities and differences. Cyclosporine is quite lipophilic and hydrophobic. It doesn't like water, so it requires special oily formulations, often involving castor oil or microemulsions, to be absorbed orally. It's available IV and orally. The original soft gelatin capsule had slow and quite erratic absorption, with bioavailability anywhere from 20–50%. The modified microemulsion formulations like Neural or Gengraph were developed to provide more uniform absorption and increased bioavailability. However, it's critical to know they are not bioequivalent to each other or the original formulation. You cannot just switch between brands or formulations interchangeably without very careful blood level monitoring, as it could lead to graft loss from underdosing or increased toxicity from overdosing.
So formulation matters a lot. Monitoring is key here too.
Absolutely. Monitoring blood levels is essential. Historically, trough levels were used, but now C2 levels, 2 hours post-dose, or even full pharmacokinetic profiles might be used, especially if there's unexplained graft dysfunction, to really understand exposure. Oral absorption is still incomplete and variable, and can be influenced by food. It distributes widely in the body. Elimination is biphasic, with a terminal half-life ranging from 5 to 18 hours. It's extensively metabolized by hepatic CYP3A4, similar to tacrolimus, producing many metabolites, though most have reduced activity or toxicity. Excretion is primarily via bile into the feces. Dosage adjustments are needed for liver dysfunction, but usually not for dialysis or kidney failure itself, although the drug is nephrotoxic. It's also excreted in human milk.
What are its main uses and toxicities compared to tacrolimus?
Key indications are kidney, liver, heart, and other organ transplantation. Also rheumatoid arthritis, psoriasis, and severe dry eye disease, ophthalmia. It's usually combined with other agents, glucocorticoids, azathioprine, or mycophenolate, sometimes sirolimus in a multi-drug regimen. Because of the necrotoxicity concern, the initial dose is often given after the transplant surgery, not before. Dosing is guided by signs of rejection or toxicity and those crucial blood levels. A major challenge is differentiating kidney toxicity caused by the drug from actual rejection. Often a kidney biopsy is the only definitive way. Specific uses outside transplant include severe rheumatoid arthritis, RA, that hasn't responded to methotrexate. It can be combined with methotrexate but requires careful monitoring. And severe recalcitrant psoriasis. It's also shown efficacy in other T-cell mediated diseases like Behçet's disease, uveitis, atopic dermatitis, inflammatory bowel disease, and certain types of nephrotic syndrome.
And the side effects. You mentioned nephrotoxicity and hypertension.
Yes, those are the principal adverse reactions. Renal dysfunction and hypertension are very common and often dose-limiting. Tremor is also frequent. Hirsutism, excessive hair growth, hyperlipidemia, high cholesterol triglycerides, and gum hyperplasia, overgrowth of gum tissue, are also quite common with cyclosporine. It can cause hyperuricemia, potentially worsening gout. Now, comparing toxicities again, while both calcineurin inhibitors can be diabetogenic, this seems to be a more significant problem with tacrolimus. Conversely, cyclosporine is more likely to significantly increase LDL cholesterol levels than tacrolimus.
So different metabolic profiles. What about drug interactions for cyclosporine? Still a big concern.
Huge concern. It's crucial to monitor because of the potential for wide-ranging interactions, especially with drugs that affect CYPs, particularly CYP3A4. Just like tacrolimus, many common drugs can interfere. Inhibitors of CYP3A4, like certain calcium channel blockers, verapamil, diltiazem, antifungal agents, ketoconazole, atraconazole, antibiotics, erythromycin, even glucocorticoids themselves, HIV protease inhibitors, allopurinol, metoclopramide, and yes, grapefruit juice can increase cyclosporine concentrations, risking severe toxicity. Conversely, inducers of CYP3A4, like antibiotics such as nafcillin and rifampin, anticonvulsants, phenytoin, phenobarbital, carbamazepine, octreotide, taclopidine can decrease cyclosporine concentrations, increasing the risk of graft rejection. You also need to be careful combining it with sirolimus. Separate administration times are needed because cyclosporine can aggravate sirolimus nephrotoxicity and increase sirolimus-induced hyperlipidemia and myelosuppression. Additive nephrotoxicity can occur with NSAIDs. Cyclosporine can also reduce the clearance of other drugs like methotrexate, prednisolone, digoxin, and statins, potentially increasing their toxicity. So medication reconciliation is incredibly important for patients on cyclosporine.
Shifting gears now to the antiproliferative and antimetabolic agents. These drugs target the very growth and replication of immune cells, hitting them where it counts in a different way, right? By stopping them from multiplying.
Exactly. These agents inhibit the proliferation of lymphocytes, thus reducing the available army of immune cells. Let's start with sirolimus, which is also known as rapamycin. It's an mTOR inhibitor.
mTOR, that sounds familiar from cancer treatments too.
It is indeed. MTOR is a key pathway in cell growth and proliferation, so it's a target in both immunology and oncology. Sirolimus's mechanism is quite distinct from the calcineurin inhibitors. It inhibits T lymphocyte activation and proliferation downstream of the IL-2 and other T-cell growth factor receptors. Like cyclosporin and tacrolimus, it first forms a complex with an immunophilin in this case, FKBP12, the same one tacrolimus binds to. But critically, this sirolimus FKBP12 complex does not affect calcineurin activity. Instead, it binds to and inhibits the protein kinase MTOR, mammalian target of rapamycin.
So it hits a different target even though it uses the same binding partner initially.
Precisely. MTOR is a key enzyme in cell cycle progression. By inhibiting MTOR, sirolimus blocks cell cycle progression at the G1 to S phase transition. This effectively stops lymphocytes from dividing and proliferating in response to growth signals like IL-2.
Interesting. Does it have any other unique properties?
Yes, it does. In animal models, sirolimus not only inhibits transplant rejection, GVHD, and autoimmune diseases, but it also shows effects that can last for several months after the drug is discontinued. This suggests it might have a tolerizing effect, potentially retraining the immune system slightly. A newer indication emerging is its use specifically to avoid calcineurin inhibitors, maybe even switching stable patients off them, precisely to protect long-term kidney function.
How is it handled by the body? Absorption, metabolism?
It's rapidly absorbed orally, usually peaking in the blood within 1–2 hours. However, its systemic availability is only around 15%, and taking it with a high-fat meal decreases the peak concentration. This means consistent administration, always with food or always without food, and close blood level monitoring are crucial for maintaining stable levels. It partitions significantly into blood cells. It's extensively metabolized by CYP3A4 and also transported by P-glycoprotein, another factor influencing drug interactions. Excretion is mainly via feces. Sirolimus itself is the major active component responsible for most of the immunosuppressive effect. It has a very long blood half-life, around 62 hours after multiple doses, which means a loading dose can help achieve steady-state levels more quickly, usually within a day.
What are its main uses and side effects?
It's used for the prophylaxis of organ transplant rejection, usually in combination with reduced doses of a calcineurin inhibitor and glucocorticoids initially. It's also sometimes used with glucocorticoids and mycophenolate specifically to avoid permanent renal damage from calcineurin inhibitors. Dosing regimens are complex and generally guided by target blood levels, often aiming for 5–15 ng/ml, though this varies. Dose reduction is needed in patients with liver impairment. An interesting non-immunosuppressive use is its incorporation into drug-eluting stents used in cardiology to inhibit local cell proliferation and prevent blood vessel reocclusion after angioplasty.
And the downsides? Toxicity?
A notable side effect is a dose-dependent increase in serum cholesterol and triglycerides, which often requires management with lipid-lowering therapy. While sirolimus itself isn't considered directly nephrotoxic, combining it with cyclosporine can actually impair renal function more than cyclosporine alone, so that combination needs caution. It can sometimes worsen proteinuria, protein in the urine, so careful use is needed in patients with low kidney function, GFR, or existing proteinuria. An increased incidence of lymphocytes, fluid collections, has been seen post-renal transplant. Other effects include anemia, leukopenia, low white cells, thrombocytopenia, low platelets, mouth ulcers, hypokalemia, low potassium, and GI effects. It can also cause delayed wound healing. Interestingly and importantly, sirolimus seems to have anti-cancer effects, especially on skin cancer risk, which is often elevated in transplant patients due to general immunosuppression. This makes it potentially the immunosuppressant of choice in transplant recipients with a history of malignancy, especially skin cancers. It's important to differentiate it from temsirolimus, another MTOR inhibitor approved specifically for kidney cancer, and everolimus, which is used for various cancers but not specifically noted for skin cancer prevention like sirolimus. And like other immunosuppressants, there's an increased risk of infections.
Drug interactions must be a factor too, with CYP3A4 involved.
Yes, as a COP304 substrate, and also handled by the P-glycoprotein transporter, it interacts with inhibitors like diltiazem, erythromycin, ketoconazole, which increase its levels, and strong inducers, like rifampin, which decrease its levels, necessitating dose adjustments and careful monitoring.
What about everolimus and temsirolimus? Are they similar?
Everolimus is chemically related to sirolimus, but has distinct pharmacokinetics, notably a shorter half-life. Its toxicity profile and drug interaction potential are generally similar to sirolimus. Individualization of drug dose through therapeutic drug monitoring is required for everolimus as well. Temsirolimus, as mentioned, is another MTOR inhibitor specifically approved for treating advanced renal cell carcinoma, kidney cancer.
Okay, let's move to azathioprine. This one's been around a while too, hasn't it? An antimetabolite?
Yes. Azathioprine is a purine antimetabolite derived from an older cancer drug called 6-mercaptopurine, or 6-MP. It was one of the earliest effective immunosuppressants used in transplantation, often combined with steroids before cyclosporine came along. Its mechanism involves it being cleaved, mainly by non-enzymatic reaction with nucleophiles like glutathione, into 6-MP. 6-MP is then converted through complex enzymatic pathways into metabolites that inhibit de novo purine synthesis, the building blocks for DNA and RNA. Furthermore, a fraudulent nucleotide called 6-THIO-IMT gets incorporated into DNA, which inhibits cell proliferation and impairs various lymphocyte functions, including T-cell and B-cell responses. Azathioprine itself is actually more potent as an immunosuppressant than 6-MP.
How's it handled? Absorption, metabolism?
It's well absorbed orally, peaking in the blood within 1 to 2 hours. The half-life of azathioprine itself is very short, only about 10 minutes, and 6-MPs is about 1 hour. But some of the active metabolites persist much longer, up to 5 hours. Blood levels haven't shown good predictive value for efficacy or toxicity, so monitoring is usually based on clinical response and blood counts. It's rapidly metabolized, mainly in the liver and red blood cells. Renal clearance has minimal impact, so dose adjustment isn't typically needed for kidney failure.
What are its main uses and side effects today?
It's still used as an adjunct for preventing organ transplant rejection, though often replaced by mycophenolate now. It's also used for treating severe rheumatoid arthritis, particularly cases unresponsive to other therapies. Typical starting doses are given in the sources, but monitoring complete blood count and liver function tests regularly is crucial. The major and most feared side effect is bone marrow suppression. This usually manifests as leukopenia, low white blood cell count, which is most common, but also thrombocytopenia, low platelets, and rarely anemia. This suppression increases susceptibility to infections, especially viruses like varicella, chickenpox shingles, and herpes simplex. Other adverse effects can include hepatotoxicity, liver damage, alopecia, hair loss, GI toxicity, pancreatitis, and an increased risk of neoplasia cancer, particularly skin cancers and lymphomas, with long-term use.
Are there critical drug interactions to know about?
Yes, there's one crucially important interaction. An enzyme called xanthine oxidase is involved in catabolizing, breaking down, the active metabolites of azathioprine. This enzyme is blocked by the drug allopurinol, which is commonly used to treat gout. Combining azathioprine with allopurinol leads to dangerously high levels of the azathioprine metabolites and severe, potentially fatal bone marrow suppression. This combination should generally be avoided, or if absolutely necessary, the azathioprine dose must be drastically reduced by about 65–75% with extremely close monitoring. Co-administration with other myelosuppressive agents, like chemotherapy drugs, or even ACE inhibitors can also lead to enhanced leukopenia, thrombocytopenia, and anemia.
That allopurinol interaction sounds really critical. Okay, finally in this group, mycophenolate mofetil, or MMF. This one seems more commonly used now than azathioprine in transplants.
Yes, MMF has largely replaced azathioprine in many transplant protocols, often perceived as being more effective and potentially having fewer side effects like liver toxicity, although direct comparisons can be complex. It's actually a prodrug, meaning it's inactive itself but is rapidly hydrolyzed in the body to its active form, mycophenolic acid, or MPA.
And how does MPA work?
MPA is a selective, non-competitive, and reversible inhibitor of an enzyme called inosine monophosphate dehydrogenase, or IMPDH. This enzyme is absolutely critical in the de novo pathway of guanine nucleotide synthesis, another essential building block for DNA. Now, B and T lymphocytes are particularly highly dependent on this de novo pathway for their rapid proliferation when activated, more so than other cell types which can use salvage pathways. Therefore, MPA selectively inhibits lymphocyte proliferation functions, including antibody formation by B cells, and also affects cellular adhesion and migration. It's more specific to lymphocytes than azathioprine.
How is MMF handled by the body?
It's rapidly and completely metabolized to the active MPA after oral or IV administration. MPA is then further metabolized, mainly in the liver, to an inactive glucuronide metabolite, MPA, which is primarily excreted in the urine. MPA itself has a half-life of about 16 hours. Plasma concentrations of both MPA and the inactive MPA increase significantly in patients with renal insufficiency, though dose adjustment recommendations vary.
What are its main uses and toxicities?
It's indicated for the prophylaxis of transplant rejection, kidney, heart, liver. It's typically used in combination with glucocorticoids and a calcineurin inhibitor. Importantly, it should not be used concurrently with azathioprine because they both target purine synthesis, leading to excessive myelosuppression. Combining it with sirolimus is possible, but requires careful monitoring. Approved doses vary depending on the organ and patient population. MMF is also increasingly used off-label for autoimmune conditions like systemic lupus, MS, and sarcoidosis. There's also a delayed-release formulation of MPA available, which might cause less GI upset for some patients. The principal toxicities are gastrointestinal diarrhea and vomiting, are common in immunological, primarily leukopenia, but also sometimes pure red cell aplasia. There's an increased incidence of some infections, especially CMV, cytomegalovirus sepsis. Also, the combination of tacrolimus plus MMS has been linked to the activation of polyoloviruses, particularly BK virus, which can cause interstitial nephritis and damage a transplanted kidney. And crucially, MMF use during pregnancy is associated with a significant risk of congenital anomalies, birth defects, and an increased risk of pregnancy loss, miscarriage. It is absolutely contraindicated in pregnancy, and effective contraception is mandatory for women of childbearing potential during treatment and for a period after stopping the drug.
That's a critical warning. What about drug interactions for MMF?
Some notable interactions exist. Tacrolimus can actually delay the elimination of MMF by impairing the conversion of MPA to the inactive MPA, potentially enhancing GI toxicity. Antacids containing aluminum or magnesium hydroxide can decrease MMF absorption, so they shouldn't be taken simultaneously. Cholestyramine, a bile acid sequestrant used for high cholesterol, and other agents that affect intrahepatic circulation can decrease plasma MPA concentrations by binding free MPA in the intestines. Drugs like acyclovir and ganciclovir, antivirals, may compete with MPA for tubular secretion in the kidneys, potentially increasing blood concentrations of both drugs. Interestingly, routine monitoring of MMF serum levels, MPA levels, is not generally performed or recommended in clinical practice, unlike with calcineurin inhibitors or sirolimus.
Okay, we've covered the broad suppressors like steroids, the calcineurin inhibitors hitting T-cell activation, and the antimetabolites stopping cell division. But you mentioned the field has moved towards even more precise immunomodulatory approaches. What really defines these? How are they different?
Immunomodulation, in this context, really refers to therapeutic approaches that are precisely targeted to a specific molecular driver or interaction within the immune response. So instead of broadly dampening the entire immune system like, say, high-dose steroids do, these drugs focus on specific components, maybe a particular cytokine, a specific receptor on an immune cell, or a key cell surface interaction needed for activation. The goal is a much more refined, less generalized effect, hopefully leading to fewer off-target side effects while still achieving the desired control over the immune response.
More like a sniper rifle than a shotgun.
Exactly. A much better analogy.
What's fascinating here is how T-cell activation itself, that complex process we discussed, provides critical points for these targeted interventions. You mentioned signal 1 and signal 2.
Right. Understanding the intricacies of T-cell activation and regulation is key to immunotherapy development. Full T-cell activation follows what's known as the two-signal model. Signal 1 is the primary antigen-specific signal. The T-cell receptor, TCR, recognizing the specific MHC antigen complex on the antigen-presenting cell, APC. That's the what identifying the specific threat. But that's not enough on its own. A signal 2, or co-stimulation, is also absolutely required for full activation and proliferation. A classic crucial co-stimulatory interaction is between the CD28 protein on the T cell and the CD80, also called B71 or CD86, B72 proteins on the APC. Without this second go signal, even if the T cell recognizes the antigen, signal 1, it can become anergic, basically functionally paralyzed and unresponsive, or even undergo programmed cell death, apoptosis. Other co-stimulatory signals like CD154 on the T cell interacting with CD40 on the APC can further enhance T cell activation. So you can immediately see how blocking these critical second signals becomes a powerful and more targeted way to inhibit an unwanted immune response.
Block signal 2, stop the T-cell even if it sees the target. Makes sense. What about inhibition?
Right, it's not all go signals. In what you might call an anti-parallel system to activation, we also have immune checkpoints. These are points of negative regulation, essentially built-in brakes. Certain interactions actually provide inhibitory signals, reducing T-cell activation and preventing overreaction or autoimmunity. Key examples include the interaction of CTLA4, another protein on T cells structurally similar to CD28, competing with CD28 to bind CD8086, but delivering an inhibitory signal instead. Another major one is the PD-1 receptor on T cells interacting with its ligands PD-L1 and PD-L2, often found on APCs and also some tissue cells, including tumors. These PD-1 interactions deliver strong stop signals. These checkpoints are vital for maintaining immune homeostasis and self-tolerance. What's fascinating, and has revolutionized cancer treatment, is that blocking these very checkpoints using antibodies against CTLA4 or PD-1, PD-L1 can release the brakes, permitting T-cell activation to proceed unfettered. This allows the immune system to unleash a powerful attack on tumor cells that it might otherwise ignore or be suppressed by.
So understanding both the go and stop signals gives us multiple points to intervene. Antibodies seem to be a huge part of this targeted approach. Let's start with those targeting specific T-cell components directly.
Antibodies have truly revolutionized targeted therapy, allowing us to hit specific molecules with high precision. First, let's look at anti-CD3 monoclonal antibodies. CD3 is a core component of the T-cell receptor complex itself, essential for signaling. Antibodies directed against its epsilon chain can induce T-cell inactivation and rapid removal from circulation through mechanisms like endocytosis and phagocytosis. The original murine, mouse-derived antibody, murmonab CD3 or OKT3, was highly effective at reversing acute rejection but caused severe side effects, notably cytokine release syndrome, cytokine storm, and pulmonary edema due to widespread T-cell activation before depletion, leading to its discontinuation in the U.S. Newer, genetically altered humanized anti-CD3 mAbs, like teplizumab, were developed to minimize these anti-antibody responses and avoid binding to Fc receptors on other cells, thereby reducing side effects while still effectively mediating T-cell modulation. These are being explored beyond transplant rejection, with teplizumab showing promise in clinical trials for significantly extending the time before diagnosis in high-risk individuals for type 1 autoimmune diabetes.
Moving on, what about anti-CD52 monoclonal antibody, alemtuzumab? You mentioned it earlier for induction.
Right. Alemtuzumab is a humanized monoclonal antibody that binds to the CD52 protein. CD52 is a small protein that's widely expressed at high levels on the surface of both B cells and T cells, as well as monocytes, macrophages, NK cells, and some granulocytes. Its function isn't fully understood, but binding alemtuzumab to it triggers antibody-dependent cell-mediated cytotoxicity and complement-dependent cytotoxicity, CDC, leading to rapid and profound depletion of these circulating lymphocytes. This depletion can last for a very long time, sometimes over a year. Therapeutically, it's used primarily for induction immunosuppressive therapy and transplants, often allowing for early avoidance of high-dose steroids. A common regimen might be just a single 30 milligram dose given intraoperatively. It's also used sometimes for refractory acute cellular and antibody-mediated rejections that haven't responded to other treatments. Beyond transplant, it's licensed for treating certain types of chronic lymphocytic leukemia, CLL, and also for relapsing forms of multiple sclerosis.
Profound depletion sounds effective, but risky.
It is. Neutropenia, low neutrophils, is the most common adverse effect. Thrombocytopenia and anemia can also occur. A major concern with alemtuzumab, especially in the context of MS treatment where it's given repeatedly, is the development of secondary autoimmune diseases, like autoimmune thyroid disease or immune thrombocytopenia, even autoimmune hemolytic anemia, occurring months or years later. This is thought to be related to the pattern of immune reconstitution after such profound and widespread lymphocyte depletion.
Then there are the anti-IL-2 receptor, anti-CD25 antibodies like daclizumab and basiliximab. How do they differ?
These antibodies target the alpha subunit of the high-affinity interleukin-2 receptor, also known as CD25. This receptor subunit is typically only expressed at high levels on activated T cells, as well as regulatory T cells. Daclizumab, humanized, and basiliximab, chimeric, bind with high affinity to CD25 and act as receptor antagonists. They inhibit T-cell activation and proliferation by blocking IL-2-mediated signaling, basically preventing IL-2 from delivering its potent growth signal. Crucially, they do this without inducing cell lysis or depletion.
So they block activation but don't kill the cells.
Exactly. Daclizumab has a lower affinity, but a much longer half-life, around 20 days, compared to basiliximab, half-life about 7 days. They are used for induction therapy and solid organ transplantation, often as part of a multi-drug regimen. Daclizumab was also developed and approved for MS, though its use has been significantly curtailed due to safety concerns related to inflammatory brain conditions. Basiliximab remains widely used for transplant induction, typically given as 2 doses, one before transplant and one a few days after. The dosing regimen for basiliximab usually saturates the IL-2 receptors on circulating lymphocytes for about 25-35 days. Both are generally considered relatively safe as induction agents, with adverse reaction rates comparable to placebo in trials. No significant cytokine release syndrome occurs, though rare anaphylactic reactions, lymphoproliferative disorders, and opportunistic infections can still happen. No major drug interactions are reported.
Moving to another highly targeted agent, we have belatacept, which you mentioned is a fusion protein and blocks co-stimulation. Can you elaborate on that?
Yes, belatacept is quite different. It's a second-generation CTLA-4Ig fusion protein. It essentially combines a modified Fc fragment of human immunoglobulin G1 with the extracellular domain of CTLA-4. also known as CD152. It was engineered with specific amino acid substitutions that give it increased affinity for binding the costimulatory ligands CD80 and CD86, about twofold higher for CD80, fourfold higher for CD86 compared to a prior version called abatacept. This increased binding affinity translates into about a tenfold increase in vitro potency.
So it binds tighter to block signal 2. How does that work in practice?
Belatacept acts as a selective T-cell costimulation blocker. By potently binding to CD80 and CD86 on the surface of antigen-presenting cells, it physically interrupts their interaction with the CD28 receptor on T cells. This inhibition of signal 2 effectively inhibits T-cell activation, promoting a state of T-cell energy, unresponsiveness, or even apoptosis, programmed cell death. It stops the activation process before it really gets going. From a practical standpoint, it's the first intravenous maintenance therapy approved in solid organ transplantation. It has predictable, linear pharmacokinetics and a relatively long half-life of about 11 days, allowing for less frequent dosing over time.
What are its main uses and downsides?
Preclinical studies showed it prolonged graft survival, though it didn't reliably induce true tolerance on its own. It's FDA approved as an alternative to calcineurin inhibitors, specifically to help patients avoid the long-term toxicity associated with CNIs, particularly nephrotoxicity. It's approved for prophylaxis of organ rejection in adult kidney transplant recipients, usually given in combination with basiliximab induction, MMF, and corticosteroids. Clinical trials, like the BENEFIT study, demonstrated better kidney function and improved metabolic profiles, like less new-onset diabetes, with belatacept compared to cyclosporine-based regimens over several years. The infusion frequency decreases over time, starting relatively frequently early post-transplant and tapering down to once per month for maintenance. However, there's a significant concern. An increased risk of post-transplant lymphoproliferative disorder, PTLD, particularly in the brain, was observed in clinical trials, especially in patients who were Epstein-Barr virus, EBV, seronegative before transplant, meaning they hadn't been previously exposed to EBV. Because of this risk, its use is now restricted to only EBV seropositive patients. Infusion-related reactions are infrequent, and otherwise is generally well tolerated. No specific pharmacokinetic drug interactions have been reported.
Beyond these interactions on the cell surface, targeting specific cytokines, those chemical messengers, has revolutionized treatment for a variety of inflammatory and autoimmune conditions. What are some of the key players here?
That's right. Cytokines are powerful chemical messengers driving inflammation, and precisely targeting them has opened up entirely new therapeutic avenues, particularly in rheumatology and dermatology. Let's start with the big one, anti-TNF regions. Tumor necrosis factor alpha, TNF, is a key pro-inflammatory cytokine deeply involved in the pathogenesis of numerous immune-mediated diseases affecting the gut, skin, and joints. Think rheumatoid arthritis, Crohn's disease, psoriasis. Levels are often elevated in active disease. Several highly effective agents target TNF. Infliximab is a chimeric, part mouse, part human, IgG1 monoclonal antibody. It binds TNF with high affinity, preventing it from binding to its receptors and triggering inflammation. It's approved in the U.S. for symptoms of rheumatoid arthritis, often combined with methotrexate, moderate to severe Crohn's disease, especially when conventional therapy fails, ankylosing spondylitis, plaque psoriasis, psoriatic arthritis, and ulcerative colitis. Infusion reactions like fever, hives, low blood pressure, shortness of breath can occur. Rarely, patients can develop anti-nuclear antibodies or a lupus-like syndrome. Etanercept is different. It's a fusion protein. It links the ligand-binding portion of the human TNF receptor to the Fc portion of human IgG1, so it acts like a soluble decoy receptor, soaking up TNFR before it can bind to cell surface receptors. It's approved for RA, ankylosing spondylitis, plaque psoriasis, polyarticular juvenile idiopathic arthritis, and psoriatic arthritis. It can be used with methotrexate. Injection site reactions are common as it's given subcutaneously. Adalimumab is a fully human recombinant IgG1 mAb, also given subcutaneously, with broad indications similar to infliximab and etanercept. Golimumab is another human IgG1 anti-TNF mAb, approved alone or with methotrexate for RA, psoriatic arthritis, ankylosing spondylitis, and ulcerative colitis, subcutaneous. And certolizumab pegol is a humanized antibody fragment specific to TNF linked to polyethylene glycol pegylated to extend its activity. It's approved for Crohn's disease, RA, psoriatic arthritis, and ankylosing spondylitis, subcutaneous.
That's a lot of options for TNF, but they must have risks too.
Absolutely, and this is critical. The FDA has issued a black box warning across all these anti-TNF agents concerning an increased risk of serious infections. This includes bacterial infections, invasive fungal infections, tuberculosis reactivation, and opportunistic infections. There's also an increased risk of lymphomas and other malignancies. Fatal hepatosplenic T-cell lymphomas, a rare but aggressive cancer, have been reported, particularly in young patients with Crohn's disease treated with infliximab in combination with azathioprine or 6-MP. So careful patient selection and monitoring for infection and malignancy are essential.
Okay, TNF is a major target. What about other cytokines like IL-1?
Yes, IL-1 inhibition is another strategy, as interleukin-1 levels are also elevated in many active inflammatory conditions. Anakinra is an FDA-approved recombinant non-glycosylated form of the human IL-1 receptor antagonist, IL-1RA. It basically blocks IL-1 from binding its receptor. It's used for joint disease and rheumatoid arthritis, certain rare autoinflammatory syndromes called cryopyrin-associated periodic syndrome, CAPS, and neonatal onset multi-system inflammatory disease, NOMID. It can be used alone or with some other DMARDs, but importantly, the combination with anti-TNF agents like etanercept or infliximab is not recommended due to a significantly increased risk of serious opportunistic infections and neutropenia. Live vaccines should also be avoided. Canakinumab is a monoclonal antibody specifically targeting IL-1, approved for CAPS, and active systemic juvenile idiopathic arthritis, and has been evaluated for conditions like COPD. Rilonacept is another IL-1 inhibitor, a fusion protein which has been evaluated for gout, as IL-1 plays a key role in the inflammatory joint pain caused by uric acid crystals.
And beyond IL-1, there are many other interleukins involved in immunity.
Indeed, the field is rapidly expanding to target other key interleukin pathways. IL-6 receptor antagonists. Interleukin-6 is another major pro-inflammatory cytokine. Tocilizumab blocks the IL-6 receptor and has broad approval for RA, systemic juvenile idiopathic arthritis, giant cell arteritis, polyarticular juvenile idiopathic arthritis, and even for managing severe cytokine release syndrome caused by CAR T-cell therapy. Serlimab is another IL-6R antagonist for RA. Satralizumab targets the IL-6R for neuromyelitis optica spectrum disorder. Ciltuximab is an antibody that binds IL-6 itself, used for multicentric Castleman disease. A key risk with IL-6 blockade is an increased risk of serious infections and potential hepatotoxicity, liver issues. IL-12 and IL-23 pathway blockers. These cytokines are involved in Th1 and Th17 cell differentiation, important in psoriasis and inflammatory bowel disease. Ustekinumab targets the common P40 subunit shared by both IL-12 and IL-23. It's indicated for plaque psoriasis, psoriatic arthritis, Crohn's disease, and ulcerative colitis.
More recently, selective targeting of just the IL-23 pathway via its unique P19 subunit has been achieved with monoclonal antibodies like guselkumab, risankizumab, and tildrakizumab. These are primarily indicated for moderate to severe plaque psoriasis, with guselkumab also approved for psoriatic arthritis. The longer half-lives of tildrakizumab and risankizumab allow for less frequent maintenance dosing every 8-12 weeks. All carry an increased risk of serious infections. IL-17 pathway inhibitors. IL-17 is a key cytokine produced by Th17 cells, driving inflammation in conditions like psoriasis and ankylosing spondylitis. Secukinumab, a human anti-IL-17 AMAB, and ixekizumab, a humanized anti-IL-17 AMAB, are indicated for plaque psoriasis, psoriatic arthritis, and ankylosing spondylitis. Brodalumab inhibits the IL-17 pathway by targeting the IL-17 receptor, a subunit. A significant warning here. These agents carry an increased risk of serious infections and also potentially inflammatory bowel disease, Crohn's, ulcerative colitis requiring monitoring. Crucially, brodalumab carries an FDA black box warning for suicidal ideation and behavior, requiring careful patient screening and monitoring.
There are also many other biologicals emerging, targeting type 2 immune responses like IL-4, IL-5, IL-13, IL-33, TSLP, primarily for treating asthma and atopic dermatitis. The field is incredibly active.
Wow, targeting individual cytokines or their receptors is incredibly specific. But what's really fascinating is a newer strategy that targets not the cytokines themselves, but the shared intracellular pathways they activate after binding to the receptor. Tell us about JAK inhibitors.
This is a truly revolutionary area, representing a major shift in therapeutic strategy. While the biologicals targeting single cytokines or receptors were transformative, they have limitations. Sometimes patients don't respond adequately, or they lose response over time. Plus, there's often complex crosstalk between different cytokine pathways. This led researchers to look downstream, to target shared intracellular signaling molecules that transduce signals from multiple different cytokine receptors. The idea is that by hitting these common nodes, you might inhibit the function of several inflammatory pathways concomitantly. JAK inhibitors, or JAK inhibs, are the prime example of this approach and a key active area of drug development.
So they block the signal inside the cell after the cytokine binds outside. How does that work?
Exactly. The mechanism centers on Janus kinases, or JAKs. These are a family of protein tyrosine kinases, JK1, JK2, JK3, and TYK2. When a cytokine binds to its receptor on the cell surface, it brings receptor chains together, activating the associated jakes. These activated jakes then phosphorylate the receptor itself and also other downstream signaling proteins, most notably the STAT proteins, signal transducers and activators of transcription. These phosphorylated STATs then dimerize, move into the nucleus, and initiate the transcription of numerous genes involved in mediating the cytokine's biological functions, including inflammation, immune cell proliferation, and survival. JAK inhibitors available today mostly work by targeting the ATP binding site of one or more JAK isoforms, preventing them from carrying out their phosphorylation function, thus blocking the JAK-STAT signaling pathway. Some newer ones in development are allosteric inhibitors, binding elsewhere on the enzyme. Because different cytokine receptors pair with different combinations of JAKs, the available JAK inhibitors have varying specificities and therefore slightly different effects, though many inhibit multiple JAKs to some degree.
And these have been approved for quite a few conditions already.
Amazingly fast development. In just the past decade or so, 10 different JAK inhibitors have gained regulatory approval worldwide for a remarkably diverse range of indications. This includes rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, polycythemia vera, graft versus host disease, myelofibrosis, ankylosing spondylitis, allergic dermatitis, and atopic dermatitis. Key FDA-approved examples include ruxolitinib, baricitinib, opadacitinib, abrocitinib, fedratinib, pacritinib, and tafasitinib. Others are approved elsewhere. Clinical trials are ongoing for many other autoimmune and inflammatory conditions, and development continues towards more specific inhibitors, like TYK2 or JAK3 specific agents, or even non-absorbable forms for treating gut inflammation locally.
Being oral drugs must be a big advantage over injectable biologicals. How are they handled?
Yes, being oral is a major convenience factor. JAK inhibitors are generally rapidly absorbed after oral administration, reaching peak plasma concentrations quickly. Metabolism varies. Ruxolitinib is metabolized mainly by CYP3A4, tafasitinib by CYPs 3A4 and 2C19. This means potent CYP inhibitors, like ketoconazole, or inducers, like rifampin, can significantly affect their half-life and exposure, requiring dose adjustments. Baricitinib is a bit different. It's not extensively metabolized, but is a substrate for kidney transporters like OAT3, P-glycoprotein, and BCRP, leading to active renal secretion. Inhibitors of these transporters, like probenecid, can increase baricitinib levels. Dose adjustments are often needed for liver and/or renal impairment for several JAK inhibitors.
What about interactions and toxicities? They sound powerful.
Generally, JAK inhibitors are not recommended for use in combination with other strong systemic immunosuppressants like biological DMARDs, or potent immunosuppressants like azathioprine or cyclosporine due to the risk of excessive immunosuppression. As mentioned, they interact with potent CYP inhibitors or inducers. A crucial point is vaccinations. Patients should complete all age-appropriate vaccinations, especially for varicella zoster virus, shingles, prior to starting JAK inhibitor therapy, and live vaccines must be avoided during treatment due to the immunosuppression. Toxicities are a significant concern. Like most immunosuppressants, JAK inhibitors carry an increased risk of infection, including upper respiratory infections, sinus infections, common colds, but also more serious ones like reactivation of hepatitis C virus or herpes zoster virus, shingles. Common side effects can include anemia, thrombocytopenia, leukopenia, lymphopenia, hyperlipidemia, increased cholesterol, diarrhea, headache, and high blood pressure. Crucially, several JAK inhibitors, specifically baricitinib, tafasitinib, and upadacitinib, have been shown to significantly increase the risk of venous thromboembolism, VTE, including deep venous thrombosis, DVT, and pulmonary embolism, PE. And perhaps most importantly, the FDA has mandated a black box warning for all oral JAK inhibitors used chronically for inflammatory conditions. This highlights several major increased risks observed in post-marketing safety studies, particularly one involving tafasitinib compared to TNF inhibitors in RA patients, serious bacterial, fungal, viral, and opportunistic infections leading to hospitalization or death, a higher rate of all-cause mortality, including sudden cardiovascular death, a higher rate of certain cancers, particularly lymphoma and lung cancer, especially in current or past smokers, a higher rate of major adverse cardiovascular events, MACE, including cardiovascular death, myocardial infarction, heart attack, and stroke, especially in current or past smokers and those with other cardiovascular risk factors. Thrombosis, blood clots.
Wow, that's a sobering list of warnings. It really underscores the need for careful patient selection and monitoring.
Absolutely. Clinicians need to be acutely aware of these risks when initiating therapy, monitor patients very closely, adhere to recommended usages, often after failure of other agents like TNF inhibitors, and educate patients about potential adverse reactions. It's a powerful class of drugs, but requires very careful management.
Beyond blocking signaling pathways, there are also specific agents targeting lymphocyte adhesion and migration, basically stopping immune cells from getting to where they need to go to cause trouble.
Yes, controlling immune cell trafficking is another key strategy. One older example is alifacip. This is a human LFA3 IgG1 fusion protein. Its alpha-3 portion binds to the CD2 protein on T lymphocytes. This blocks the essential interaction between alpha-3 on APCs or other cells and CD2 on T cells, which is another accessory interaction involved in T cell activation and adhesion. Alifacip was approved for psoriasis. Interestingly, it was shown to dose-dependently reduce T effector memory cells, but not naive T cells. This was significant because T effector memory cells are thought to be particularly resistant to co-stimulation blockade and transplantation. While it showed some promise in non-human primate transplant models, a phase 2 study in human kidney transplant recipients showed no benefit over placebo, and its use has largely declined.
What about newer agents targeting migration? You mentioned natalizumab earlier for MS.
Right, natalizumab and vedolizumab are key examples of biologicals targeting integrins. Leukocyte migration from the bloodstream into tissues, a critical step in inflammation, depends on integrins, which are adhesion molecules on the leukocyte surface, interacting with their ligands, which are cell adhesion molecules expressed on the endothelial cells lining blood vessels. This interaction allows leukocytes to arrest, stick to the vessel wall, and then squeeze through into the tissue transmigration. Integrins are heterodimers, made of IN and VALI subunits. Natalizumab targets the I4 subunit, which is part of both the iophorone integrin, also known as VLA4, and the I47 integrin. Vedolizumab, on the other hand, is more selective and specifically blocks only the I47 integrin.
Why does that selectivity matter?
It matters because of tissue specificity. The ligand for ID7 integrin, called MADCAM1, mucosal addressing cell adhesion molecule 1, is primarily expressed on endothelial cells in the gut mucosa. So blocking the ID47 MADCAM1 interaction specifically reduces leukocyte homing to the inflamed intestine. In contrast, the ID41 integrin interacts with VSAM1, vascular cell adhesion molecule 1, which is crucial for T cell trafficking across the blood-brain barrier. Blocking this interaction, as natalizumab does, effectively inhibits T cell infiltration into the central nervous system.
So natalizumab for the brain, MS, vedolizumab for the gut, IBD.
Broadly speaking, yes. Natalizumab is indicated for adult patients with relapsing forms of multiple sclerosis, RMS, and active secondary progressive MS. It's also indicated for moderate to severe Crohn's disease in patients who haven't responded to conventional therapies or TNF inhibitors. Vedolizumab, being the gut-selective ID47 integrin antagonist, is indicated for moderate to severe Crohn's disease and ulcerative colitis.
What about toxicities? You mentioned PML with natalizumab.
Yes, that is the major concern. A significant risk with natalizumab is progressive multifocal leukoencephalopathy, PML. This is a rare but often devastating opportunistic viral brain infection caused by the John Cunningham virus, JCV, which resides latently in many people. PML can lead to severe disability or death. The risk of PML increases significantly with certain factors. The presence of anti-JCV antibodies in the patient's blood, indicating prior exposure, longer duration of natalizumab treatment, especially beyond 2 years, and prior use of other immunosuppressant medications. Because of this risk, natalizumab is only available through a restricted distribution program, REMIS in the U.S., that requires regular JCV antibody testing and careful patient monitoring for any neurological signs or symptoms suggestive of PML.
Is PML a risk with vedolizumab too?
The risk appears to be much lower with vedolizumab, likely due to its gut selectivity and lack of effect on CNS immune surveillance. Only one potential case has been reported as of the source material, but monitoring for neurological signs is still generally recommended. Both drugs, by modulating immune trafficking, can increase the general risk of infections. Natalizumab, due to its specific inhibition of T cell trafficking into the CNS, is also associated with an increased risk of herpes, encephalitis, and meningitis.
We've talked a lot about blocking immune components. Are there also therapies that use cytokines themselves to modulate the immune system?
Yes, although perhaps less common now with the advent of more targeted agents, cytokine therapy has played a role. Interferon therapy, particularly interferon beta, IF-NDO, was actually among the first cytokine-based therapies approved for autoimmune diseases, specifically for multiple sclerosis back in the early 1990s. Interferons are endogenous regulatory cytokines produced by the body that modulate gene transcription through multiple mechanisms, including inducing anti-inflammatory cytokines like IL-10, Various IFN-VAR formulations given by injection showed modest efficacy, decreasing MS exacerbation rates by about 30%. They are relatively safe, with flu-like symptoms and fatigue being the main side effects. However, with the development of much more efficacious drugs for MS, IFN-VAR preparations are no longer considered first-line therapy. IFN-VAR are used more for infections or certain cancers. Another example is granulocyte macrophage colony-stimulating factor, GM-CSF. This is a cytokine and growth factor that stimulates hematopoietic stem cells, HSCs, in the bone marrow to differentiate into granulocytes, neutrophils, eosinophils, basophils, and monocytes.
A recombinant form, sorgramostim, is approved therapeutically not for immunosuppression, but for the opposite, to boost immune cell production. It's used to accelerate myeloid reconstitution after bone marrow or peripheral blood progenitor cell transplantation, to help neutrophil recovery after chemotherapy, and even in cases of myelosuppressive radiation exposure.
Finally, you mentioned earlier that B cells are becoming a bigger focus, especially in transplant rejection. What therapies are targeting them specifically?
That's a really important shift. For decades, most advances in transplantation immunosuppression focus heavily on targeting T-cell responses. As those therapies improved, T-cell-mediated acute rejection became less problematic. However, this unmasked the significance of B-cell-mediated responses, such as antibody-mediated rejection, AMR, driven by donor-specific antibodies, DSAs, which are now a major cause of late graft loss. This has spurred the development of biologicals and small molecules with B-cell-specific effects. Examples include belimumab, a monoclonal antibody that targets BLYS, B lymphocyte stimulator, also known as BAFF, a crucial survival factor for B cells. Belimumab is approved for systemic lupus erythematosus, SLE, a disease where B cells play a central role. And as we touched on before, the CD20 antibodies like rituximab, Chimeric, and ocrelizumab, humanized, have had a major impact. CD20 is a protein expressed on the surface of most B cells, from pre-B cells through mature B cells, but not on plasma cells, the final antibody-producing stage. These antibodies effectively deplete circulating mature B lymphocytes, though some may remain protected in lymph nodes or tissues. The remarkable success in clinical trials for rheumatoid arthritis and multiple sclerosis strongly suggests a critical role for B cells in the pathogenesis of these diseases, likely extending beyond just antibody production. Definitive genetic studies also point to B cells' crucial role as potent antigen-presenting cells, APCs, capable of activating T cells. Targeting B cells is definitely a major frontier in immunomodulation.
With all this talk of suppression and modulation, managing side effects, lifelong therapy, what's the ultimate goal, the holy grail in all this incredible research into manipulating the immune system?
The ultimate goal, the true holy grail for both organ transplantation and autoimmune diseases, is to induce and maintain immunological tolerance.
Tolerance, meaning the immune system accepts it.
Exactly. But it's not just ignoring it. Tolerance is an active antigen-specific state of non-responsiveness. The immune system actively learns to recognize the specific antigen, whether it's from the transplant or the body's own tissue in autoimmunity, as safe or self, and specifically doesn't mount a destructive response against it, while still remaining fully capable of fighting off infections and cancers. If we could achieve true, durable tolerance, it would represent a genuine cure, eliminating the lifelong need for broad immunosuppression and all its severe debilitating side effects. Imagine transplant patients living without daily anti-rejection pills, or people with autoimmune diseases being truly free from their condition. That's the dream.
Does any of this new research we've discussed actually point towards achieving that dream? Or is true tolerance still largely theoretical?
There are definitely promising avenues being actively researched, moving beyond theory into preclinical and even some clinical exploration. We're seeing hints. For example, remember how we discussed sirolimus, the mTOR inhibitor? Interestingly, while calcineurin inhibitors can actually prevent the induction of tolerance in some preclinical models, sirolimus does not seem to. In fact, some studies suggest it may even promote tolerance. Well, in experimental animal models, sirolimus has been shown to promote the development and function of regulatory T cells, TREGs. These are that specialized subtype of T cells we mentioned earlier, whose job is specifically to suppress unwanted immune responses and promote tolerance. And studies in human kidney transplant recipients have shown that sirolimus tends to spare these crucial regulatory T cells in the periphery, maintaining their percentage, whereas calcineurin inhibitors often reduce their numbers. This preferential sparing of TREGs by sirolimus is a significant clue that it might be more compatible with or even helpful for achieving tolerance.
What about blocking those costimulatory signals? Signal 2.
Yes, costimulatory blockade is another major strategy actively pursued for tolerance induction. As we discussed,
Preventing that crucial second signal required for full T-cell activation has been shown in many preclinical models to induce a state of T-cell energy or tolerance rather than just temporary suppression. Abatacept, a CTLA-4 Ig fusion protein related to belatacept, is an example currently used clinically. It competitively inhibits the CD28-CD80-86 interaction and is proven effective in rheumatoid arthritis, suggesting this pathway is viable. Earlier attempts using monoclonal antibodies against CD154, also known as CD40 ligand, another key costimulatory pair, in renal transplantation and autoimmune diseases showed great promise for tolerance, but were unfortunately discontinued due to unexpected thromboembolic events, blood clots. However, this initial promise has spurred the development of alternative, hopefully safer approaches targeting co-stimulation pathways.
Are there other approaches, maybe more radical ones?
Well, donor cell chimerism is a fascinating and potentially curative approach, though complex. This strategy involves first significantly dampening or even temporarily eliminating the recipient's existing immune system, maybe using radiation, chemotherapy like cyclophosphamide, or specific depleting antibodies. Then a new source of immune function is provided by adoptively transferring bone marrow or hematopoietic stem cells from the organ donor.
So you're essentially giving the recipient a piece of the donor's immune system.
Exactly. As the recipient's immune system reconstitutes from these donor stem cells alongside their own remaining cells, it effectively learns during development to recognize the donor's antigens, including those on the transplanted organ, as self. This can lead to a state of mixed chimerism and potentially long-lived tolerance, often allowing for significant reduction or even complete withdrawal of traditional immunosuppressive drugs like calcineurin inhibitors. It's being actively trialed, particularly in combined kidney and bone marrow transplants.
What about using the specific antigens themselves?
That's another cutting-edge area. Using specific antigens to induce tolerance. There are numerous fascinating preclinical models where researchers have successfully induced immunological tolerance in animal models of diseases like diabetes mellitus, arthritis, and multiple sclerosis by administering specific disease-relevant antigens in particular ways. For example, orally, nasally, or coupled to nanoparticles. The idea is to selectively tolerize or switch off only the immune response directed against those specific antigens, without causing the systemic toxicity associated with broad immunosuppressive therapies. This offers the promise of highly specific immune therapies, a true antigen-specific tolerance. However, translating the success from animal models to effective therapies in humans has proven very challenging so far, but the potential is enormous.
And you mentioned soluble HLA earlier, from blood transfusions.
Yes, that's a historical clue that's still intriguing. Back in the pre-cyclocerin era, it was consistently observed that patients who received blood transfusions, especially from their eventual organ donor, donor-specific transfusions or DST, had significantly better kidney transplant outcomes, less rejection. These DST protocols actually improved graft survival rates.
Strange, giving more foreign material helped.
It seemed counterintuitive, right? While these effects became less pronounced or necessary after the introduction of powerful T-cell blockers like cyclosporine, the apparent tolerance-promoting effects of transfusions were undeniable. The speculation is that this effect might be mediated, at least in part, by HLA molecules present either on the surface of the transfused cells or perhaps shed in soluble forms in the plasma. Indeed, subsequent research in animal models has shown that purified soluble HLA molecules or even specific peptides derived from them can induce immunological tolerance through various mechanisms, possibly involving the generation of regulatory T cells or inducing energy in reactive T cells. It's still an area of active investigation trying to harness that naturally observed phenomenon in a more controlled way. All these avenues represent the leading edge of research aimed at achieving that ultimate goal, a life free from rejection and immunosuppression.
Okay, let's try to bring all this incredibly complex information to life now by focusing on one specific disease where these therapies are making a profound impact: multiple sclerosis. How do all these different drugs and concepts targeting T cells, B cells, cytokines, migration actually fit together in managing a real-world condition like MS?
Multiple sclerosis, or MS, is a perfect case study because its treatment landscape has been utterly transformed by these immunomodulatory therapies. MS is understood as a genetically mediated chronic inflammatory disease where the immune system mistakenly attacks the central nervous system, CNS, specifically the myelin sheath that insulates nerve fibers, and also the nerve fibers themselves, axons. This leads to demyelination and neurodegeneration, causing a wide range of neurological symptoms. It's characterized by that fundamental loss of immune tolerance to CNS components, essentially an autoimmune attack on the brain and spinal cord.
What do we know about its cause and who gets it?
The detailed etiology, the precise cause, remains unclear, likely a complex interplay of genetic predisposition and environmental factors. Its prevalence generally increases from late adolescence up to about age 35, then declines. It's significantly more common in females, about 2–3 times more so than males. Geographically, it's predominantly found in populations residing in higher latitudes of temperate climates away from the equator. Epidemiological studies suggest various environmental factors might contribute to risk, including low vitamin D levels linked to less sunlight exposure, smoking, increased body mass index during adolescence, and possibly even high salt intake.
And the genetics.
Genome-wide association studies, GWAS, have been hugely informative, identifying over 200 distinct genetic variants associated with MS susceptibility. Many of these variants fall within genes involved in specific immune signaling cascades, suggesting that alterations in these pathways might even predict how well a patient responds to certain therapies down the line. Interestingly, over half of these MS risk variants are also found in other autoimmune diseases, highlighting shared underlying mechanisms. These risk alleles are primarily linked to genes regulating immune function, and the variants themselves are often enriched in binding sites for key immune-related transcription factors, suggesting they affect gene regulation within the immune system.
So what does the immune system look like in someone with MS?
In MS patients, we find activated T cells in the blood and cerebrospinal fluid that are reactive to various myelin antigens components of that insulating sheath, like myelin basic protein, MBP. These activated T cells tend to secrete pro-inflammatory cytokines like interferon gamma and IL-17, which drive inflammation in the CNS. In contrast, T cells from healthy individuals, if they react to myelin at all, tend to secrete anti-inflammatory cytokines like IL-10. The IL-2 receptor signaling pathway, which we discussed as crucial for T cell activation and proliferation, is particularly prominent in understanding MS pathogenesis and is a target for some therapies.
How is the disease classified? Does it progress differently in people?
Yes, MS presents in different patterns. Attacks, or relapses, are classified by type and severity, corresponding to areas of damage, lesions in the CNS. The main critical courses are relapsing remitting MS, RRMS. This is the most common form, affecting about 85% of patients initially, especially younger individuals. It's characterized by distinct neurological attacks, relapses, followed by periods of partial or complete recovery, remission. Secondary progressive MS, SPMS. Many people with RMS eventually transition to SPMS, which involves a more progressive neurological deterioration over time, with or without superimposed relapses. Primary progressive MS, PPMS. About 15% of patients experience PPMS, where neurological function worsens steadily from the onset of symptoms, typically with relatively little overt inflammation or distinct relapses.
Since there's currently no cure for MS, what are the main goals of pharmacotherapy using all these drugs we've discussed?
While there's no pharmacological cure yet, the goals of pharmacotherapy are clear and impactful. First, to resolve acute attacks when they happen. Second, to reduce the frequency and severity of future relapses or exacerbations. And third, and perhaps most importantly, to slow the underlying progression of disability accumulation over the long term. These goals are achieved using a growing arsenal of immunomodulatory disease-modifying therapies, or DMTs, which are available as both parenteral, injectable or infused, and oral agents. It's worth noting that many of the newer, highly effective agents come with a significant annual cost.
How are acute attacks handled?
Acute exacerbations, those sudden flare-ups of symptoms, are typically treated with a short course of high-dose corticosteroids, usually methylprednisolone, given either orally or intravenously for 3 to 5 days to quickly reduce inflammation.
And the long-term disease-modifying treatments? What are the general principles?
The DMTs are the cornerstone of long-term management. They aim to modulate the underlying disease process. These agents have been shown in clinical trials to significantly reduce relapse rates in RMS and SPMS, and some now also slow disability progression. Current thinking often favors starting with higher efficacy therapies early on. Initial treatment for RMS might involve anti-CD20 antibodies, ocrelizumab or ofatumumab or natalizumab. For highly active disease, alemtuzumab, natalizumab, or the oral S1PR modulators might be considered. A key principle is that these potent disease-modifying agents generally should not be co-administered with other strong systemic immunosuppressive drugs due to the potential for additive immunosuppression and increased risks. It's absolutely essential to follow the specific FDA-approved or other regulatory agency instructions for initiation, maintenance dosing, and required monitoring for each agent due to their distinct potential adverse effects, drug interactions, and potential for fetal harm during pregnancy. Importantly, evidence strongly suggests that earlier initiation of DMTs is generally more effective in reducing long-term disability. Clinical trials consistently show relapse rate reductions, ranging from about 34% to as high as 68% compared to placebo, depending on the drug and patient population.
Let's break down some of the specific agents used for MS, starting with the parenteral ones.
Okay. The first-generation injectable agents were interferon-beta, IFN-beta, and glatiramer acetate, GA. As we mentioned, IFN preparations like Avonex, Bedaciran, Rebif offered modest therapeutic efficacy, reducing exacerbation rates by around 30%. They are relatively safe, with flu-like symptoms and fatigue being common side effects. Glatiramer acetate, GA, Copaxone, is introduced as a random synthetic polypeptide mixture designed to mimic myelin basic protein. It binds to MHC class II molecules and is thought to work partly by inducing cross-reactive CD4 plus T cells that secrete anti-inflammatory Th2 cytokines like IL-4, IL-13. It also showed about a 30% reduction in exacerbation rates similar to IFN-BEP. It was an early example of attempting to ameliorate autoimmune disease by altering TCR signals with an altered peptide ligand. However, long-term MS treatment has largely shifted towards more effective targeted treatments, so initiating therapy with IFN or GA first-step therapy before using more potent drugs like ocrelizumab or natalizumab is generally not favored anymore.
What about the more potent parenteral options?
Big steps up in efficacy came with antibodies. We discussed natalizumab, Tisabri, the antibody targeting AVO4 integrin. By blocking T-cell trafficking into the CNS via the AF41-VCM1 interaction, it's highly effective in inhibiting MS exacerbations, often reducing relapse rates by close to 70%. It's given as an IV infusion typically every 4 weeks. But, as we stressed, its use is significantly limited by the risk of PML, requiring participation in the REMS program and careful JCV antibody status monitoring. JCV-negative patients are often considered good candidates, while JCV-positive patients might be steered towards other options. Then we have the antibodies to CD20, the B-cell depleting therapies, ocrelizumab, Ocrevus, and ofatumumab, Kesimpta. These have proven highly efficacious. Ocrelizumab is a humanized antibody given by IV infusion every 6 months. Ofatumumab is a fully human antibody given by subcutaneous injection monthly after initial loading doses. Both are approved for relapsing forms of MS, RMS, and active SPMS. Significantly, ocrelizumab is also the first and currently only drug approved for primary progressive MS, PPMS.
Rituximab, Rituxan, the older chimeric anti-CD20 antibody, has also been used effectively off-label for MS for many years, and alemtuzumab, Lemtrada, the antibody targeting CD52. As mentioned, this humanized MAD causes profound and long-lasting depletion of CD52-positive cells, including B and T lymphocytes. It's approved for relapsing forms of MS, but is generally reserved for patients who have had an inadequate response to 2 or more other DMTs. This is due to the significant risks associated with its use, including potentially serious infusion reactions, the high risk of secondary autoimmune reactions, thyroid disease, ITP, kidney disease, emerging months or years later, and a potential association with malignancy. It has a unique dosing schedule. An initial course of daily IV infusions for 5 consecutive days, followed 12 months later by a second course of daily infusions for 3 consecutive days. Despite the risks, it's highly effective, showing superiority over IFN-MOA in preventing relapses in clinical trials. Due to fetal harm risk, effective contraception is required during treatment and for 4 months after the last dose. Lastly, briefly, metoxantrone, an anthracynidone chemotherapy agent that inhibits DNA replication, has shown some effect in reducing relapse rates and slowing MS progression, given as a short IV infusion every 3 months. However, its use is severely limited by significant long-term cumulative risks, particularly cardiotoxicity, heart damage, and therapy-related acute myeloid leukemia, greatly reducing its safety profile for a chronic condition like MS-SCID.
Okay, those are the injectables and infusions. What about the oral agents for MS? That must be more convenient for patients.
Yes, the development of effective oral DMTs has been a major advance for patient convenience and adherence. First, the S1PR modulators. Fingolimod, Gilenya, Siponimod Mayzent, Ozanimod Zeposia, and Ponesimod, Ponvory. We touched on their pharmacology earlier. They functionally antagonize sphingosine-1-phosphate receptors, S1PRs, on lymphocytes. This traps lymphocytes within lymph nodes, preventing their egress into the circulation and subsequent trafficking into the CNS. Fingolimod was the first, a non-selective S1PR modulator, acting on S1PR1, 3, 4, and 5, while the newer agents, Siponimod, Ozanimod, Conissimod, are more selective, primarily targeting S1PR1 and S1PR5, which might offer a better safety profile regarding some side effects like cardiac effects. Fingolimod is actually a prodrug, needing phosphorylation to become active. All 4 are approved for relapsing forms of MS, with Siponimod also specifically approved for active secondary progressive anascript.
They are generally considered high-efficacy therapies, often reducing exacerbation rates by about 50% compared to placebo. A crucial warning. MS can worsen significantly, sometimes with severe rebound activity, upon withdrawal of these agents, so discontinuation needs careful planning. Common side effects include increased risk of infections, especially herpes viruses, potential liver enzyme elevation, macular edema, eye swelling, and effects on heart rate and conduction, requiring monitoring, especially at initiation. Next are the fumarates. Dimethyl fumarate, Tecfidera, and its relatives, diroximel fumarate, Vumerity, and monomethyl fumarate, Bacterium. These oral agents have multiple immunomodulatory and potentially neuroprotective effects used for relapsing forms of MS. The detailed mechanism isn't fully known, but they are all metabolized to monomethyl fumarate, MMF, the active form. MMF is thought to activate the NRF2 pathway, which mediates cellular responses to oxidative stress. It's also a nicotinic acid receptor agonist, which likely contributes to the common side effect of cutaneous flushing. They reduced annualized relapse rates by about 50% compared to placebo. They're generally considered safe, but gastrointestinal side effects, nausea, diarrhea, abdominal pain, are common, especially initially. More seriously, they can cause significant lymphopenia, low lymphocyte counts, and have been associated with rare cases of PML and other serious opportunistic infections, viral, fungal, bacterial. Regular monitoring of blood counts, lymphocytes, and liver function is required before and during treatment. Typical dosing involves starting at a lower dose and titrating up to the maintenance dose. Then there's teriflunomide, Aubagio. This oral agent works by reversibly inhibiting a key mitochondrial enzyme called dihydrotate dehydrogenase, DHODH. This enzyme is essential for de novo pyrimidine synthesis, another crucial pathway for the proliferation of rapidly dividing cells like activated B and T lymphocytes. By inhibiting pyrimidine synthesis, teriflunomide reduces lymphocyte proliferation. It carries FDA-boxed warnings for hepatotoxicity, liver injury, and teratogenicity, risk of birth defects. Liver function tests and bilirubin must be monitored before starting and periodically during treatment. It is absolutely contraindicated in pregnancy and requires extensive procedures, including a drug elimination procedure using cholestyramine or activated charcoal for women wishing to become pregnant or if pregnancy occurs. It can also interact with drugs metabolized by CYPs 2C8 and 1A2. For example, it might reduce the effect of warfarin. Approved for relapsing forms of MS, it reduced annual relapse rates by approximately 34% in clinical trials compared to placebo. Finally, cladribine, Mavenclad. This is an oral purine nucleoside analog, essentially an antimetabolite. It's FDA approved for relapsing forms of MS, or RMS, and active SPMS, typically reserved for patients who have had an inadequate response to or cannot tolerate other DMTs. Cladribine selectively targets and depletes lymphocytes, particularly B cells, through mechanisms involving DNA strand breakage and inhibition of DNA synthesis and repair. It also carries FDA-boxed warnings for increased risks of malignancies, cancer, and teratogenicity. Cancer screening, according to standard guidelines, is recommended before and during treatment. It is contraindicated in pregnancy and in patients with active malignancy. Patients are at increased risk for opportunistic infections, including PML, though rare, and hepatic damage. Cladribine has a unique oral dosing regimen. Treatment consists of just 2 short courses of tablets, taken about a month apart each year for 2 years. After the 2 annual courses, no further cladribine treatment is needed for the following 2 years, total 4-year study period. In trials, this regimen reduced annual relapse rates by approximately 50-58% compared to placebo. #TAG-TAG-ATRO.
Wow, what an absolutely incredible journey into the intricate world of immunology and its modulation. From the fundamental self versus non-self recognition, all the way to these highly specialized drugs, battling rejection and autoimmunity. It's just crystal clear that this field is a constant, delicate balance of power and precision.
It really is. We've truly peeled back the layers today, haven't we? Exploring how all these different drug classes, from the broad-acting glucocorticoids that started it all to the very targeted JK inhibitors and monoclonal antibodies, how each plays a vital role in managing incredibly complex conditions like organ transplant rejection and multiple sclerosis. Understanding that there's specific mechanisms, their detailed pharmacokinetics, how the body handles them, and crucially, their unique toxicity profiles and potential drug interactions. That knowledge is absolutely key to navigating these powerful therapies safely and effectively in a clinical setting.
This deep dive really makes you appreciate the constant evolution in medicine, the move from what were once relatively blunt instruments, maybe like sledgehammers, to these highly refined targeted therapies, more like scalpels. It's truly astonishing to see that progress.
Absolutely. And the goal is always pushing towards greater precision, achieving the desired immune modulation with the fewest possible side effects, always moving towards that ultimate aim we discussed. inducing true antigen-specific immunological tolerance. That's where the most profound potential lies for improving long-term health and really the quality of life for patients facing these challenging conditions.
So what does this all mean for you, our listener, now that you've absorbed all this incredibly detailed information?
Well, I think it means that the frontier of medicine continues to advance at a remarkable pace. It's offering increasingly personalized and effective ways to manage some of the most challenging diseases known to humankind. The sheer depth of this information underscores not only the complexity involved, but also the immense promise held within our growing ability to manipulate the immune system in ways we could only have dreamed of just a few decades ago.
And for you, our now very well-informed learner, here's a provocative thought to consider as we wrap up. As our understanding of immunity becomes ever more precise, as we learn to target pathways with increasing specificity, could we one day design immune therapies that are so tailored, so exact, that they can effectively cure conditions like autoimmunity or prevent transplant rejection by simply subtly retraining our immune system, maybe with virtually no side effects, essentially making our bodies perfectly accept what was once foreign or stop attacking what is self? It's a fascinating future to imagine.